Immune system genes, what we discover is that the genetic distance, the differences between the allele frequency of the common variants is huge, 10 times higher than other genes. Why is that? Because infectious disease is a huge selection pressure which is molding and affecting gene frequencies. CCR5 delta 32 is but one example. This slide just simply illustrates for you about 20 different immune response genes. In European Americans, their frequency versus African Americans. Look at this one, look at this one, look at this one, look at this one, look at this one. These are differences of 10, 20, 40%. Generally speaking, the lion's share of the genes that are different between ethnicities are in immune response genes because of this event. So this means that we need to pay close attention not only to the Caucasian cohorts that I've described, but to cohorts being developed in Africa and Asia. And that's really what I've been spending my time on the last 4 or 5 years, is going there. Now I'd just like to thank my collaborators. First, the ones at NCI, and I'm sorry you can't read this, but there are people in the laboratory who developed things. These are the collaborators who developed the different cohorts, the epidemiologists who spent the last 20 years watching and processing and collecting information. The GWA itself is being run by a bunch of young people in our laboratory, headed by Jen Troyer. She's the one who's doing the filters on the AFI chips and producing the data and generating the informatics for analysis. This is a picture of Cher Hendrickson, who's responsible for the heart therapy, Bailey Kessing, who built all the databases, Jen Troyer, who's running it, Jim Laudenberger, who's developed a lot of the software, such as RGRay, George Nelson, the head of our bioinformatics section on Ping, who's basically been working a lot of Canada genes with Sherry Winkler and Mary Carrington. And now I'd like to finally thank you all for your kind attention.
We have a few minutes for questions. We're opening the floor up to any questions.
Steve, I noticed one of your slides. This is the V64I mutation.
Yes.
It seems like it's the only one, when you're comparing it against the protective effect in the natural history versus when you take heart into consideration, it was the only one that was a disconnect, that it was green. It was protective when you looked at the natural history, when you took into consideration,
Yeah, that was in the heart result, and it basically was a discrepancy.
So the slope was fast.
That's right. I don't think I have an explanation for that. It's just one of those exceptions that comes up when you're looking at these things. It could be that the effect is a statistical artifact. There could be a functional explanation. But most of them seem to track the correct direction pretty well.
Because to this day, we still don't know what the V64I does.
Well, this is controversial too. 64I, for those of you who don't know, is one of the AIDS restriction genes that was discovered 10 or 11 years ago. It's a minor co-receptor, and a bunch of studies we did with Bob Domes and Ben Hurley, who's you, is still here, okay, failed to discover what it was. But as you know, Carlos Martinez has postulated that it may have a role in binding of CCR5, which differentially the two allelic products actually, the two allelic products have a differential avidity, slowing it down. Now that was not replicated by Bob, and he doesn't believe it. I expect you don't believe it, but I haven't seen a better explanation yet. So we're sort of at the stage now of waiting for the functional virologist to help us here.
Other questions? I actually have a question. Can you speak a little bit, the last two slides talked about the differences
Yes.
Across ethnicities. Can you speak a little bit about the impact of that difference, how frequent it is in African Americans versus whites, and the impact upon the health disparity that we see with African Americans carrying the brunt of the HIV infection?
I think quantifiably, it's probably similar to a more general question, which is how much genetic differences is there in the variation between Africans and Caucasian Europeans. And we know since the 60s, and it's been replicated several times since, that about 10% of the variation is distinctive between the two groups, and 90% is overlapping, which means that there's 10 times more similarities between the ethnicities than there is differences. And that there's, and this is one of the reasons why the whole argument about, genetic determination of ethnicities is so difficult to defend. So if that's also the case with the AIDS restriction genes or the infectious disease genes, and I think it's probably a little bit higher among the defense genes, then probably what it means is that there will be some fraction of genes that will protect against AIDS in Africa and in Caucasians and in Orientals, and another fraction that will not, that'll be shared with 2 of the groups and not with a third, and then some that will be specific to each. And that's exactly what we've seen with the 20 or 30 that people have looked at. There's about 5 or 6 of the 20 AIDS restriction genes that we've looked at that are found only in African Americans. Okay? And there's a couple like CCR5 that are found only in Caucasians, delta 32. The fraction is probably going to be roughly 20 to 40% for each of those 3 groups. That is common to all, shared between 2, or unique to 1. What does that mean? It means that the imperative for setting up these kinds of longitudinal epidemiological studies, which we can connect genetics to with the present genetic technology, is huge. Because if we just concentrate on Caucasians, which is where most of the discoveries have come out so far, we're going to miss everything that's happened in Africa and in Asia, which is molded, again, by their history of outbreaks that come every 20 or 30 years to populations and have a very large effect on survival relative to this variation in immune defenses. Does that answer your question?
Yes.
Okay.
Thank you. We're going to have you come back after this. There will be another panel with all of the speakers.
Okay.
So you'll have an opportunity to ask Dr. O'Brien some more questions.
I just wanted to talk, I forgot to mention earlier, we're going to have a change in schedule today because Dr. Fenton has a plane to catch back earlier this afternoon. So after Dr. Fenton's talk, we're going to have our panel discussion. And then lunch will be about the same time, maybe push back 15 minutes. And then after lunch, come back for my talk.
Good morning, or is it? Noon or just about. My name is Dr. Gail Wyatt. I'm one of the associate directors of the AIDS Institute, and it gives me a great deal of pleasure to introduce Dr. Kevin Fenton. Dr. Fenton is an MD, PhD, and is director of the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention at the U.S. Centers for Disease Control in Atlanta. As the NCHHSTP director, Dr. Fenton oversees all of CDC's work related to the prevention, control, and elimination of HIV/AIDS, viral hepatitis, STDs, and TB in the U.S., as well as the CDC's Global AIDS Program, an implementing partner of PEPFAR. Dr. Fenton is a public health specialist and infectious disease epidemiologist with expertise in STI, including HIV, surveillance, research and prevention, health, sexual health promotion, and behavioral surveillance and research. Dr. Fenton has served on a number of academic and community leadership positions and has consistently focused on addressing racial and ethnic disparities in sexual health. He has published numerous book chapters in peer-reviewed articles in prominent journals, including The Lancet, Sexually Transmitted Diseases, AIDS, the British Medical Journal, and the Journal of Infectious Diseases. He has served on a number of notable professional committees as well as editorial boards for journals. He is a fellow of the Faculty of the Public Health of the Royal Colleges of Physicians of the United Kingdom and a visiting professor at the University of London. After graduating from the University of the West Indies Medical School in Jamaica, Dr. Fenton earned his master's in public health at the London School of Hygiene and Tropical Medicine and his PhD in epidemiology at the University College of London. I met Dr. Fenton in London when I was invited to speak several years ago at the Royal College of Medicine. I could not believe that I was asked to speak because I thought they were kidding me when they actually emailed and asked if I'd come and speak. And you know how you get the emails from other places in the world saying, would you do this and that? But actually had that opportunity. It was really a turning point in my career to speak at an institution, and I think I was the first African-descendant woman to ever speak. And it was really numbing and humbling for me. And so I started with slavery and talked about the effects of slavery worldwide on the diaspora, certainly, but also on the disparities that have resulted out of that experience that still continues today. So when the AIDS Institute Leadership Committee got together and decided that we wanted to address a topic that many people are afraid to talk about, and that is why are so many people of color, particularly those of African descent, affected by HIV and AIDS, I can think of no better person to invite than Kevin. I invite you to hear his speech, and then we're going to have a dialogue, hopefully, with Drs. O'Brien and Fenton, as we talk about genes and we talk about health disparities. Which of these is burdening which groups, and for what reason? What role do we at UCLA have to play in the UCLA community? What role do we as individuals have to play? As a person who I think represents quite a diversity in my own genomics, I'm fascinated with what Dr. Fenton has to say. Please join me in welcoming him.
I knew that would happen. Is this one?
Yeah, this one.
I'll use this instead. Oh, does it? No, I'll use this one. All right, good afternoon, everyone. Thank you for joining us for this symposium this afternoon, and thank you to the organizers for inviting me to give this talk. It is also a pleasure for me to be here at UCLA. It's the first time I'm visiting your university, despite the fact that you've had a very long and very strong history with the CDC. A number of CDC-funded studies are taken out here, and a number of your faculty members are actually partners with us at CDC in a variety of prevention interventions, a variety of prevention programming, advisory committees, etc. So I feel as if I know many of you very well. I certainly know your work very well and your contributions to the domestic HIV prevention and the challenges that we have with HIV/AIDS in the United States and around the globe. Now, for the next 20 minutes or so, what I'd like to do is to move from the particular to the general, to move from the genomic frame to the population frame. We're going to move from the individual to what's happening in communities, what's happening in countries, and what's happening certainly in the United States. I'm going to be focusing on a variety of data sources. We're going to be looking at the global HIV epidemic, and then we're going to focus specifically on what's happening in the United States. And then finally, I'm going to be discussing implications for HIV prevention. So it would be a tremendous loss if we left the session today without reflecting on the importance of the genomic information on prevention. And how do we use this information moving forward? And what indeed is its impact on how we move forward with our prevention activities? But it would also be a loss if we didn't take time to reflect on what are some of the other factors which are driving disparities in disease incidence, both in the United States and around the world. And as I go through the talk today, I'd like to give you a frame in which you need to consider and to view the data that I'm going to be presenting. That frame really takes us beyond the individual and moves upstream it recognizes that there are individual level determinants to risk behaviors. And clearly, part of our HIV prevention efforts have to be geared towards targeting individuals, whether looking at drug injecting behaviors, high-risk sexual behaviors, looking at other types of so-called risk behaviors that occur at the individual level. But we must remember that even these behaviors occur within the context of partnerships, whether sexual partnerships or drug-sharing partnerships, and that partnerships occur within the context of networks. And you'll hear more about the importance of sexual networks and the factors, the importance of sexual networks and the contributions that sexual networks play to the transmission of disease within the communities, And you'll also know that networks occur within communities and within societies. So I wanted to start with this preamble to give you some time to move from Steve's amazing genomic data to begin to prepare you to consider the information that I'll be presenting today. So let's begin by just looking at the global HIV epidemic. And in this section of the talk, what I'd like to do is to highlight to you the importance of place as a determinant of heterogeneity within epidemics, and begin to ask the question, what is it about geography that causes some of the most tremendous disparities that we're seeing around the globe as far as HIV/AIDS is concerned? Now, as you all know, there are estimated to be more than 33 million people living with AIDS, HIV/AIDS in the United States, and the number really has increased since 2001, as indicated in the first bullet point on this slide. The global prevalence of HIV is approximately 0.8%, and UNAIDS estimates that that prevalence has actually leveled since 2000. And what you will know from that is that we see tremendous heterogeneity across countries, across communities in the world. In the United States, our overall prevalence for HIV is approximately 0.49%. It's among the highest in Western industrialized countries, but substantially lower than the global prevalence for HIV. Annual deaths for AIDS have increased from 1.7 million in 2001 to approximately 2 million in 2007. But in general, deaths have declined in the last couple of years, in part because of the rapid scale-up of antiretroviral therapy availability, especially as a result of the President's Emergency Plan for AIDS Relief, or PEPFAR. So where are we now as far as HIV/AIDS is concerned around the world? Well, new HIV infections are believed to have actually peaked in the late 1990s and declined over the first part of this decade to about 2.7 million new infections occurring each year. And that decline is due to a number of factors. In part, it's because of population-wide adoption of safer sex behaviors, prevention activities, prevention interventions, both at the individual as well as the community levels. But also probably represents the importance of the scale-up of antiretroviral therapies around the world and the importance that treatment is placing on as a preventive tool by lowering community or population levels of viral load and therefore transmissibility of HIV. As we think about health disparities, I'm not only going to be speaking about race and ethnicity today. We're going to be speaking about gender. We're going to be looking at age group disparities. We're going to be taking a much broader view of disparities as far as HIV/AIDS is concerned. And certainly, one of the important findings in the global epidemic is that women now account for approximately half of the people living with HIV/AIDS around the world, and they have done so in recent years. And as many of you know, HIV is one of the leading causes of death worldwide, and the number one cause of death in Sub-Saharan and Latin America. Now, this slide just really begins to introduce the concept of place and heterogeneity of disease incidence and prevalence by place. And clearly what we see here, as I'm sure you all know, is the tremendous burden of disease which is seen in Sub-Saharan Africa, as opposed to other regions of the world. We see that parts of the northern hemisphere are relatively less affected by the epidemic, and there are a number of factors that we'll go into a bit more depth to explain why we see some of these factors. But certainly we know that there are epidemics which are intensifying, whether these are epidemics in Eastern and Central Europe, in Eastern Asia, certainly in Latin America and the Caribbean. And we're seeing more and more generalized epidemics in these regions of the world as the epidemic evolves globally. So I'm going to focus on two specific regions to highlight some of the points that I'd like to raise as far as heterogeneity and the role of place is concerned. Let's first of all start with Sub-Saharan Africa, the region where we have most HIV infections occurring currently. And as you know, it's home to about 2/3 of the people living with HIV/AIDS around the world, or about 22 million people living with HIV. This is despite the fact that Sub-Saharan Africa accounts for about 11 to 12% of the world's population. And most of the world's population of children living with HIV/AIDS, about 90%, actually live in Sub-Saharan Africa. Now, almost all nations in the Sub-Saharan African region have generalized HIV/AIDS epidemics, and in 9 countries, more than 10% of adults are estimated to be HIV positive. Swaziland, in fact, has the highest HIV prevalence anywhere in the world, and that's estimated to be about 26.1%. So about 1 in 4 Swazis are living with HIV. Now, in many countries in Sub-Saharan Africa, we're seeing tremendous evolutions in the epidemic. In some regions and in some countries, we're seeing stabilization of the epidemic. And in other areas, we're seeing declines in the epidemic as well. And again, the key features to note here are the effectiveness. We're beginning to see evidence both of the maturation of the HIV epidemic in these areas, but also the impact of population-wide as well as individual-level adoption of prevention interventions. Now, just to contrast another region before we move to the United States, I wanted to focus on Latin America and the Caribbean, because this is an area where we're beginning to see an escalation in an evolution in the HIV epidemic. And in the Caribbean, we see an adult prevalence rate of HIV of about 1.1%. And it's the second hardest hit region in the world after Sub-Saharan Africa. Nearly 2 million people are estimated to be living with HIV/AIDS in Latin America and the Caribbean, and there are about 160,000 new HIV diagnoses which are occurring each year. 10 countries in the region have generalized HIV epidemics, and specifically the Bahamas has the highest adult prevalence in the region at about 3%, while Brazil has the highest number of individuals living with HIV/AIDS, estimated to be over about 730,000. One of the key aspects of health disparities that we're particularly concerned about is the increasing feminization of the global HIV/AIDS epidemic. And yes, although the epidemic was really first described among gay and bisexual men, certainly in Western industrialized countries, very soon we realized that areas such as Sub-Saharan Africa were having a disproportionate burden of disease as well. And within these epidemics, we saw the disproportionate burden of disease among women. Women account for about half of all adults living with HIV/AIDS, and certainly the impact among women is most significant in Sub-Saharan Africa, where women represent about 59% of all adults living with HIV/AIDS. There are many reasons to explain the gender inequalities which we see for HIV/AIDS. So as we move from place to look at the role of gender, clearly we look at women's vulnerability to HIV, and this is perhaps driven by biological differences in susceptibility to HIV infection. But there is also a very rich body of research which looks at the social and economic factors which drive epidemics and the vulnerability to HIV/AIDS among women across Sub-Saharan Africa and indeed across the world. There are also huge concerns about differentials in access to prevention and care services, which can also increase women's vulnerability to HIV. We know across the world that sexual violence plays a role on women's risk, and especially young women, whether this is in negotiating safer sex, whether it is in their ability to prevent certain types of sexual practices from occurring, or whether it's the ability to negotiate health within the context within a relationship as well. So the dynamics of relationships and the gender relationships are certainly having a huge impact on the epidemic globally. And this slide is just placed here to illustrate the increased feminization of the epidemic. And what we've done here is to stratify the epidemic by the percentage of adults aged 15 and over living with HIV who are female throughout the 1990s to 2007. And we stratified this by different regions of the world. And you can clearly see both the influence here of geography by looking at the various proportions of epidemics in which have a disproportionate percentage of women who are affected by the disease. But also that over time, we're seeing that increase occurring almost uniformly across all regions of the world. So whether you're in Sub-Saharan Africa, the global picture clearly, the Caribbean, where we've seen a more than doubling of the proportion of new infections or HIV infections which are occurring among women, and similar trends occurring in Asia, Eastern Europe, and Latin America. Another aspect of the heterogeneity and disparities that we see with the global HIV epidemic is the heterogeneity which occurs by age. And I'm including this because as we move to look at the US epidemic, we'll begin to see aspects of the age group heterogeneity reflected in the US epidemic as well. So globally, there are about 2 million children living with HIV/AIDS, and each year about 370,000 new infections are occurring among teens and young adults, and about 270,000 deaths occurring among young people in 2007. AIDS orphans are a huge issue. Only this morning at breakfast, I was speaking with a number of faculty members, and we were speaking about the issue of orphans, especially in the Sub-Saharan African context, where we see the majority of AIDS orphans currently residing. Girls and young women continue to be at the center of the epidemic around the world, and certainly in Sub-Saharan Africa. And young people aged 15 to 24 years account for about 45% of new HIV infections, certainly among those 15 years and over. And in Sub-Saharan Africa, HIV prevalence rate among young women is nearly 3 times higher than the rate among young men in the same age group. So, just wanted to begin the talk by focusing on geographic heterogeneity, to look at the role of place at a macro level, to look at gender inequalities as part of the spectrum of health disparities that we should all be concerned about. And this final slide is to really illustrate the role of age and what is happening with age, both in terms of patterns of sexual mixing, patterns of risk behaviors which occur in a population, but also the effectiveness of prevention interventions which are used to target young people to have an effect on the epidemic. In the next section of the talk, I'd like to transition then to the United States. And what I'm going to be doing is presenting new data from the CDC and our partners on HIV incidence in the United States. I'm going to be looking at 2 sets of data. The first are going to be looking at estimates of new HIV infections which are occurring in the United States. And this is using population-based estimates based upon the application of new assays which are able to distinguish between recent HIV infections and long-standing HIV infections in the US. CDC has developed a new Sentinel surveillance system which involves 22 jurisdictions across the United States. And these jurisdictions test newly diagnosed individuals with HIV with these new assays. And based upon extrapolations to our understanding of the overall population of AIDS cases in the United States, we're able to determine how many new HIV infections are occurring each year. The new data on new infections are incredible because they now give us a clearer picture of the leading edge of the epidemic in the United States in a way that new diagnoses are not able to tell us. As you know, for somebody to be HIV diagnosed, it depends on their health-seeking behaviors, the availability of HIV tests, and even those who test HIV positive, we know that many of them are not in care and may therefore not be reported. So having an estimate of HIV incidence really helps us to understand how the epidemic is evolving in the United States and where we need to be targeting our interventions. But most importantly, it gives us a tool to evaluate in real time the impacts of our prevention interventions. The second data set I'm going to be showing you are our data from our extended back calculation approach. In other words, by looking at today's distribution of HIV diagnoses and AIDS diagnoses, how can we impute, by looking back in time, when new infections were likely to occur? And these new data are going to be showing us both where the bulk of new infections have been occurring in the United States, but also how the epidemic is evolving over time. So I will move on then to talk about the new data and then to begin to unpack what we know now about disparities of HIV incidence in the United States. So the top line figure that you should all be aware of, because of the past 2 months, this really has been the major news in the United States, is that for 2006, about 56,300 Americans contracted HIV. This is somewhat higher than what CDC had estimated previously, or previous estimates throughout the 1990s were that there were about 40,000 new infections of HIV occurring each year. This new estimate is higher than was previously known, but as you will see in subsequent slides, HIV incidence in the United States has remained relatively stable since the late 1990s. So let's look at different types of disparities which are occurring in the US epidemic, and hopefully in our discussions we'll have an opportunity to discuss why these disparities are occurring in the US. For the new HIV infections, about 73% of these infections occurred in men and about 27% occurred in women. And this slide just uses the extended back calculation approach to really show how HIV incidence has changed over time. And I'm going to walk you through this first slide because there are a number of other slides which are similar to this. And if you have a good grasp of what we're presenting here, it will really begin to unpack when disparities are occurring and what are some of the driving factors. So first of all, just to focus on the total numbers of new HIV infections in the US dating back to 1977. We saw a peak of the epidemic which occurred in the early to mid-1980s. And at that time, approximately 130,000 new HIV infections were occurring in the United States. We saw tremendous declines in HIV incidence towards the late 1980s and early 1990s, a slight upswing in HIV incidence towards the late 1990s, and since the late 1990s, we've seen relative stabilization in HIV incidence since that time. The pattern for males generally follows the overall incidence trends in the United States, in part because of the high proportion of new HIV infections which are occurring among men. So we saw that similar peak in the early 1980s, tremendous declines in the US. We saw increases in the mid-1990s, relative stabilization, although there have been some increases occurring in 2003 to 2006. Among women, we saw a later peak in HIV incidence, and since that time, since the early 1990s, we've been seeing a slow but gradual decline in HIV incidence in the United States. When we look at HIV incidence by transmission category, which is another type of disparity that we see that more than half of new infections which occurred in 2006 occurred among men who have sex with men. About 31% occurred among individuals who were infected through high-risk heterosexual contact, 12% in injecting drug users, and about 4% among men who have sex with men who also inject drugs. So let's look at the trends over time. And again, we'll begin to unpack some of the determinants of these trends as we move forward with this slide. Firstly, what happened with men who have sex with men in the United States? Well, unsurprisingly, because of the nature of the emergence of the epidemic in the United States, MSM really bore the brunt of the epidemic in the first part of this decade. And indeed, since 1990, MSM are the only population subgroup where we've seen consistent increases in HIV incidence over time. So from a peak in the early 1980s, we saw tremendous declines in HIV incidence to a nadir in the early 1990s, and since 1991 to 1993, HIV incidence has been increasing gradually and has been sustained among men who have sex with men. If you look at injecting drug users, this is one of the huge success stories of HIV prevention in the United States. We saw two peaks which occurred. The first in the mid-1980s and a second in the late 1980s, early 1990s. But then we've seen tremendous declines in HIV incidence among injecting drug users. And indeed, we've seen about an 80% decline in HIV incidence since the early 1990s in the United States. Among heterosexuals, highlighted here in the turquoise line, we saw again a slightly later peak in HIV incidence compared to men who have sex with men in the United States. Gradual increases throughout the 1990s, but since the mid to late 1990s, HIV incidence has been declining among heterosexuals as a group. Another type of disparity, which we mentioned before, is the disparities that we're seeing across age groups in the United States. And for the new infections which occurred in the US, perhaps what is most distressing about how HIV is evolving today in the US is that we're still seeing a substantial proportion of new infections which are occurring among young people. So about a third of new HIV infections occurred in young people aged 13 to 29, a third in those aged 30 to 39, and another third among those aged 40 and over. The key thing to note in the 13 to 29-year-old age group is that we know from our HIV diagnoses that the majority of those infections are going to be occurring in the 20 to 29-year-old age group. But nevertheless, we're seeing a tremendous ongoing epidemic and ongoing transmission of HIV among young people in the United States. Now, this always brings up spirited discussion on why we are failing young people in the US as far as HIV is concerned. The majority of these new infections are occurring among men who have sex with men, young MSM. About 70% of the infections in the 13 to 29-year-old age group are among young MSM, and about 70% of those are occurring among young black MSM. And I'll be presenting some further data on these as we begin to unpack the disparities in the United States. Another key aspect of looking at the burden of disease which is occurring is by looking at rates as well. And as you know, not only are we seeing new infections occurring across the age groups, but if we adjust these by looking at rates per 100,000, then you see the peak age group at which new infections are occurring by rates of population are in the 30 to 39 age group, the 40 to 49-year-old age group, and then the 13 to 29-year-old age group. So let's look in a little bit more detail then at some of the racial and ethnic disparities which are occurring in the United States. And I'm going to be discussing at the end of this section perhaps some of the reasons why we're seeing these disparities. And we're going to be looking again at that framework which I mentioned at the beginning of the talk. What are the individual level factors? What are the partnership factors? What do we know about sexual networks which are driving these disparities? And then finally, what are the societal level determinants of racial and ethnic disparities for HIV incidence in the United States? So again, this slide just shows you the proportion of new HIV infections by race ethnicity in 2006. Again, the denominator here is the 56,300 Americans who acquired HIV in 2006. The bulk of these infections are occurring among blacks in the US, about 45%, 35% among whites, 17% among Hispanics. Now, as I'm sure all of you know, Hispanics account for about 15% of the US population, so we do see a disproportionate disease burden in that ethnic group. And African Americans account for about 12% of the US population, so here we see a huge and severe and disproportionate burden of disease occurring among blacks in the United States. When we look at rates and we adjust the new infections, we see here evidence of this tremendous disease burden, which is seen among blacks in the US. And bear in mind, these are estimates of new HIV infections in the US. So overall, the rates of new HIV infections are approximately 22.8 per 100,000 for the United States. Among blacks, it's about 7 times the rates as occurs among whites, at about 11.5 for whites, and 83.7 per 100,000 for blacks. Hispanics, HIV incidence is occurring at about 2 to 3 times that which occurs among whites. And for other racial and ethnic groups, we're seeing relatively same for Asian Pacific Islanders and slightly higher for American Indians and Alaska Native as compared to whites. Perhaps what's most interesting is if you go back to the extended back calculation approach to look at what has happened over time with these disparities to better understand how the epidemic has been evolving and how various populations have been bearing the brunt of the epidemic as we've moved forward over time. So again, looking back to 1977, we're going to start with whites in the US. The majority of these would have been white gay men, although over time we're seeing an increasing proportion of new infections occurring among women in the United States. And unsurprisingly, we see a very similar pattern to the overall trends in the United States, with a peak in the mid-1980s, tremendous declines which occurred in the late 1980s, early 1990s, and evidence of consistent increases in HIV incidence among whites since mid to early to mid-1990s. Now, at this point, I think one of the things that we need to begin thinking about, and we'll have some time to discuss this in the Q&As, is why we saw these tremendous declines in HIV incidence after the mid-1980s. Those of you in the room who are mathematical modelers will say, well, this is probably due to differential mortality of people who were living with HIV at the time. So we were systematically losing individuals who were in that high-risk subpopulation, and therefore this had an impact on onward transmission of the disease. So we were losing hundreds or tens of thousands of gay and bisexual men in the height or peak of the epidemic. For those of you who are prevention experts, you will probably say to me, well, the declines were probably explained by the adoption of population-wide prevention interventions. So at that time, the images of HIV/AIDS on television, the images around us were of people dying from AIDS, living with Kaposi sarcoma. AIDS was a big thing, and therefore there were tremendous individual level changes which were occurring as far as adoption of safer sex behaviors or reductions in risk behaviors that were occurring. And of course, at this time, we had a tremendous scale-up in investments for HIV prevention. So we began to see at this time social marketing campaigns, very robust school-based sex education and HIV education programs. In other words, we were in a crisis mode, which probably explains some of the population-based responses to the epidemic. Nevertheless, as we look through other racial and ethnic groups, we see very different patterns occurring in the United States. Among blacks, we saw a somewhat later peak of the epidemic, and this really supports the anecdotal evidence that we now hear in retrospect from our partners working in the field, that although much of the discussion was around the impact of HIV/AIDS among white gay men at the beginning of the epidemic, many of you working in the trenches knew that African-American men, women, and gay men were becoming infected with this disease. But the peak really occurred towards the late 1980s, early 1990s. And although we saw declines which occurred throughout the 1990s, there was a second peak in 1997 to 99, and we're seeing some evidence of declining trends among African-Americans today. Among Hispanics, we never saw the level that we saw for whites or blacks in the US, in part because of the differential populations of Hispanics. But again, following peaks in the early 1980s and early 1990s, we've been seeing declines in the US. For Asian Pacific Islanders and for American Indians and Alaska Natives, this is a different scale because the numbers are tremendously different for the other racial and ethnic groups. But again, the key things to note are the increasing trends for Asian Pacific Islanders that we're observing for HIV incidence. The majority of these are occurring among gay and bisexual men in this population. And among American Indians and Alaska Natives, we've seen similar peaks occurring in the late 1980s, stabilization throughout the 1990s, a step up more recently. Now, we've recently produced some subgroup estimates of HIV incidence in the United States, which really drills down a bit deeper into what we're observing as far as disparities are concerned. For those of you who are interested, I've highlighted a resource here that I'd encourage you to look at. This was published in CDC's MMWR only last week, still available on our website. And this really tells us about not only the macro disparities that we see, whether by gender or racial groups, or by transmission categories, but for the first time begins to look at what's happening among young gay men, or among African-American women, or among black injecting drug users. And again, very important data for us as we think about refining our prevention interventions. So this is just really showing, again, the rates of new infections by gender and race ethnicity. And again, it's just unpacking what we know in terms of the disparities by gender, and within gender to look at the disparities across the racial and ethnic groups. We know that HIV incidence among men is occurring at a rate of about 6 times that in black men as compared to white men, and about 3 to 4 times that among Hispanic men compared to white men. And among women, we see tremendous disparities comparing African-American women to white women in the United States, and similarly so for Hispanic women as well. When we look at the distribution of new infections by gender, again, we see this tremendous burden of disease which is occurring among black women, especially. About 61% of new HIV infections among women are occurring among black women. About 40% of infections among men are occurring among black men. Among men who have sex with men as a group, the new data from CDC suggests that we are seeing tremendous infections which are occurring among black gay men. So despite the fact that MSM occur for only about 2 to 3% of the US population, and despite the fact that black MSM are a relatively small proportion of MSM in general, we see a tremendous burden of disease occurring among black MSM. And nearly half of new infections among MSM are occurring among white MSM, approximately 19% among Hispanics. If we further break these data down by age group categories, this is perhaps one of the most compelling pieces of data which appeared in our subgroup analyses which were published last week. And again, in this slide, what we've done is to look at men who have sex with men, and we've looked across the racial groups, and then within each racial group to look at the age group disparities of HIV incidence. So where is HIV incidence peaking within each racial and ethnic group for men who have sex with men? And we see tremendous differences across the racial and ethnic group, differences which, to me, highlight the importance of the need to truly change the way we're doing some of our prevention programming for men who have sex with men. I'd like to draw your attention to the middle set of bar charts, which focus on black men who have sex with men, where we see peak HIV incidence. The majority of HIV incidence is occurring among young black gay men, about 52%. So more than half of new infections among black gay men are occurring in that 13 to 29-year-old age group, and substantially less in older age groups over time. We see a similar pattern for Hispanic men who have sex with men, although not the tremendous burden of disease which is occurring among younger MSM relative to other age groups. And among whites, HIV incidence peaks at a slightly older age group, among the 30 to 39-year-old age group, with subsequent declines from that age group. So as we think about then these disparities, what I've really wanted to do is to give you a flavor of both the global epidemic and then more specifically the US epidemic. And within the US epidemic, to begin to unpack what we're seeing across gender, across transmission categories, and to look at how these have changed over time. I really want to encourage you to, and in our discussions, to begin to think much more holistically about the drivers. Yes, we know that genes are going to play an important part, and we are elucidating the role that genes are going to be playing. But we know that there are tremendous factors occurring at individual, partnership, network, as well as societal levels, which are also operating. So for men who have sex with men, the literature certainly suggests that there are concerns about safer sex fatigue, that we're losing generations of men who've either practiced safer sex for a long period and have decided in their 30s and 40s to do so no longer. We know that there are issues around HIV treatment optimism because of the availability of effective antiretrovirals and the positive impact that this is having both upon people living longer and healthier lives with HIV, but also the removal of fear and the removal of some of the stigma around being diagnosed with HIV among the MSM community. We know about the role of substance abuse as a driver for HIV incidence, whether this is as part of the crack cocaine epidemics among African American communities in the early 80s and early 1990s, but certainly among men who have sex with men with the emerging and the strengthening epidemics of methamphetamine and certainly alcohol among MSM communities across the United States. We also need to be very aware about changing demographic characteristics as well for men who have sex with men. The reality is that more men in the US population are reporting male homosexual behavior. And there are suggestions that we're seeing changes in the types of risk behaviors which are occurring among men who have sex with men, whether it is the increases in the proportion of men who are reporting having unprotected anal intercourse, or the proportion of men who are reporting having unprotected anal intercourse with casual sexual partners. These are demographic changes which are occurring, and we also have changes which are occurring as well in terms of the types of sexual patterns, partnerships which are occurring. And we also have evolving social and sexual networks as well among men who have sex with men, whether it is sexual networks which are driven by the internet, the reemergence of bathhouses across the United States, which really influence the types and patterns of sexual networks which are being formed, which can either facilitate or hinder the transmission of STIs. Among African Americans, it's important to realize that although some of these are going to be drivers for the epidemics among African Americans, there are some other unique features that we now understand to be driving the epidemics among African Americans, including higher rates of sexually transmitted diseases among African Americans and certainly other minority groups in the United States. And STDs facilitate both the acquisition as well as transmission of HIV. We've mentioned substance abuse. We also need to bear in mind the role of incarceration within the African American community, in part because incarceration has multiple effects. It removes men from the community, the African American community, and therefore unbalances the male to female sex ratio within communities. And this has a tremendous impact on the nature and patterns of sexual networks which are formed. So for example, we know that when you have fewer men within the population, there is a propensity towards greater partner concurrency, because the fewer men means that there are more women competing for, so to speak, the fewer available males within the population. But incarceration also has an impact of sequestering men within an environment where risk behaviors, including tattooing, injecting drug use, and unprotected male-to-male sex may be occurring as well. So we need to think about social policies which may be driving the high incarceration rates within the African American community and the consequent impact this is having on HIV incidence. Poverty, racism, discrimination, stigma, and homophobia are all part of the societal level determinants of transmission of HIV, which are going to have an impact either on the African American community or certainly among men who have sex with men as well. And when you put these two things together, it's perhaps not unsurprising to see why black gay men in the United States are going to be at such a tremendous disadvantage, because in part, they straddle both of these determinants. High rates of STDs, the stigma and homophobia, silence, discrimination within the African American community, combined with some of the other factors which may be placing men who have sex with men at increased risk as well. So in the final part of the talk, I only have a couple more slides. I just want to say that, part of what we have to do working in prevention is to look across the spectrum of what are the key drivers for the epidemics within the United States and how we should be refining our prevention interventions moving forward. I think there's some key challenges that we have ahead of us as we think about HIV. The fact that we have a substantial proportion of Americans who are undiagnosed, continuing populations of men who have sex with men who are at risk, continuing disparities which are affecting African Americans and Hispanics, limited access to effective and culturally competent prevention interventions, which are also affecting our ability to really ensure that as the epidemic is evolving in the population, we are really providing prevention interventions which are meeting the needs of these populations, and concerns about complacency as well. We haven't had a chance to speak about stigma. I'd be happy to discuss it with you over the panel discussion, but clearly changing patterns and distribution of substance abuse is certainly having an impact on the epidemic as well. We've spoken about the internet, the need for more culturally competent interventions, and of course no discussion on these data would be complete without thinking of some of the social determinants which are driving the epidemics in the United States today. As far as CDC is concerned, we are having an increasingly focused on a comprehensive prevention approach which moves us beyond the individual level determinants of these disease transmissions. So although much of our earlier interventions had been around encouraging increasing condom use or treating STDs or ensuring individuals are HIV tested, we're now moving more upstream and looking at the role of poverty, looking at the role of policies that can influence HIV prevention, looking at the role, for example, of homelessness as an intervention and preventing homelessness as an HIV prevention intervention. So as we think about structural interventions to deal with the social determinants of HIV transmission, it's important to think of those three areas: economic interventions, laws and policies, and of course ways in which we change the way we do business, both as a federal agency or as the federal government, but ways in which we collaborate and partner with our communities to be much more effective. There are some things that we'll be doing new as we move forward with these new data. We're supporting calls for a national HIV plan. We're looking very critically at our prevention portfolio, and we're going to be developing a new strategic roadmap for HIV prevention moving forward to 2020. So with that, I wanted to share with you a bit of data today to provide a little bit of context for the macro aspects of health disparities, and in that discussion to weave points regarding the importance of geography, the importance of gender, the importance of place on epidemics, the importance of structural and social factors in understanding why we see some of the disparities that we see today. With that, thank you very much. Look forward to
Roses.
What's that? Great.
I'd like to open the floor to questions, comments. Dr. Harara.
I wanted to thank you for your talk, and I had two quick questions. I haven't read all of the reports that have come out about these new statistics, but I am certainly read some of them, and I've been a little bit struck by the fact that I haven't seen very little to no discussion about the fact that wondering what's being done about that or why it hasn't been a greater focus of discussion.
Two reasons why it perhaps hasn't been a greater focus of. Sure. Our colleague is just highlighting the trends that we saw among Asian Pacific Islanders and asking why we haven't heard more about it, because it's one of the ethnic groups where we're seeing these increases. Partly, it's a matter of magnitude. And you'll see that there were completely different scales. We're talking about 800 new infections per year versus tens of thousands of new infections in the other racial and ethnic groups. But in recent publications, and if you read them, we have certainly made a specific effort to talk about the increases, because the proportionate increases occurring among American Indians and Asian Pacific Islanders are far outstrip anything we're seeing for the other racial groups. So it's the conflict between the magnitude versus the proportionate increase, and trying to get those messages right. And it's very difficult in some of our public health messages to talk about, this is a huge increase, and then the journalists will say, well, it's only, and I don't mean to say this disrespectfully, journalists will say, well, it's only 200 cases. So it's getting that balance right, but you're absolutely correct.
My other question had to do with the data on the young MSM.
Mm-hmm.
But we looked at YMS data, young men survey data, and we compared for each of the racial ethnic groups, we looked at young men 15 to 16, 17 to 18, and we found very much what you saw here, that if you compared the men, black men 15 to 17 to like 18 to 19, there was this huge jump in infection.
Yeah.
And it really seemed like they were getting infected within a year or two of starting to have sex with other men.
Yeah.
And I'm wondering, when you talk about prevention and the challenges just of having any sex education in schools, much less something that's really addressing issues of same-sex sexuality, how we can really address it before people get infected.
So the question here is around black gay men and the tremendous increase in HIV incidence which occurs relatively quickly within their sexual career. And thank you very much for raising this question, because it is a great concern to us. It's probably akin to what we see in Sub-Saharan Africa, where for young women who begin their sexual career, if you look at the data for Southern Africa, for example, or for South Africa, you see these huge increases in prevalence for young girls by the time they're 16, 17, 18, 19. And there are a number of things to explain that. One is patterns of sexual mixing, where you have the age discordant mixing, so older male partners infecting the young women. We have data now, CDC has data to suggest that the patterns of sexual mixing for young black gay men are in fact different to young white gay men. Young white gay men are likely to be more age assortative, whereas black young gay men are more age disassortative. So they tend to have partners who are 3 to 4 years older than them. And with the high incidence driving, in the high background prevalence in the community, driving incidence, it's a lethal combination. So very similar to what we're seeing in Sub-Saharan Africa, we're seeing in young gay men in a way that one wouldn't have expected, just because of that patterns of age mixing. What the data also show are that these young black gay men do not have higher rates of partner change than white young gay men. They have lower use of drug use than white gay men. And a number of the classic risk behaviors which are associated with HIV incidence in white gay men are not seen in young black gay men. So actually, we're talking here about, and this is where place comes in, the importance of the environment. So for that single sexual encounter that young gay man will have, young black gay man will have, depending on who he's having sex with, within what context, that young person is going to be at much higher risk of acquiring HIV. So to get to the first part of your question, what do? We need to have comprehensive sex education programs in schools in the United States. We need to have authentic conversations about these data. More importantly, we need to have community mobilization at a larger scale so that the black gay community can say, this is not acceptable. We know that prevalences in many cities in the US are actually quite high, and we really need now to be working with the community to see what we need to do to protect that young generation of MSM coming in.
I'd like to add something to this, just so that it will spark some more hands flashing up. I'm always concerned as a clinician, as a mother of a son, when I see 13-year-old boys being lumped into a category with 26-year-old grown men. And if these are indeed MSM, so be it. But when you are 13, did anyone in this room know for sure about their sexual orientation, I see a few hands. But for the majority, looking at the age sorting that Dr. Fenton is discussing, I have to be concerned because the patterns that they exhibit are not the patterns of highly sexually active individuals. If these are young boys who are being sexually victimized because they are vulnerable, perhaps in situations, urban areas where there's not a lot of supervision, where there may not be the kinds of people in the home or in the family to protect them, if they're not being preyed upon by other individuals, and Drs. Williams and a number of other people in this room and I have done some studies looking at the prevalence of sexual abuse amongst African American and Latino men, and it's quite high. And you hear the stories of men saying, I didn't know that I was gay or same gender loving when I was a little boy, but the men in my town or the men in my project or in my community took advantage of me and they raped me, and I didn't know what to do because I was a little black boy and I was supposed to be strong. So I can't help wondering if we don't need to get deeper into those data to not just lump those little boys, because I consider those boys, okay, as I would an 18-year-old, lumped into 26-year-olds, and look at what's happening to those youngsters that may better help us to understand the types of interventions that are needed. Because just to assume that they are willfully and in very sophisticated ways making decisions about their sexuality when they're a very young, uninitiated boy, to me is very surprising, and I don't see that in the studies that I've done with heterosexual boys.
Okay, great point.
So I hope you'll say something about that.
Well, it's actually somewhat unrelated, but I was interested that, I think your talk was very clear. I was interested that you focused on disparities in new infections, and I'm wondering if there's any research on disparities in access to ARVs and care and treatment. And you mentioned that, that's part of the gender impact of the epidemic in Sub-Saharan Africa especially, but I read recent research, and I don't remember the name at all, but it came out of Lilongwe in Malawi, saying that women actually disproportionately access ARVs, and that especially men and particularly pediatric infections are very, very underrepresented in terms of being on treatment. So I'm wondering if you have any similar data to that in the U.S. and what are some of the reasons? So while the patterns of new infections, in other words, might be very different for disparities in accessing healthcare and other social support services, given, as we know, that women are probably, in many settings, more likely to access health services than men or children.
So thank you very much for that question, and you're absolutely right. Clearly, in a talk like this, we need to focus, and so I didn't get into much of the data to support or to really make the argument about healthcare access and the role that that plays. But yes, there are tremendous data, both not related to HIV, but generally in the United States, looking at the tremendous disparities on health insurance coverage by racial and ethnic group, by the proportion of individuals who have accessed their providers in the last year, and looking at the uptake of HIV testing, et cetera, across the racial and ethnic groups. Now, paradoxically, HIV testing is highest among African Americans compared to other racial and ethnic groups. So that suggests two things to me. One, the force of infection within the African community is so much higher because of the higher background prevalence that even with the higher rate of HIV testing and the adoption of safer sex behaviors among those who are positive, we're not able to catch up with HIV testing being an effective prevention strategy. We also know that not only are there problems with HIV testing, but as we were speaking at breakfast this morning, concerns with linkage to care, concerns with adherence to therapy and care once you're in care. And these are all socially determined, and they're social constructs around your adherence and your ability to access curative services in the US. And the data are quite stark when you look at who has access to high quality care in the US and where.
A question for Dr. O'Brien. One of the, when one looks at the distribution of HIV in Sub-Saharan Africa, one is struck by what happened in East Africa, but then the overwhelming burden that's occurred as HIV migrated southward as you get into Malawi, Mozambique, Swaziland, South Africa, Zimbabwe, Botswana, and now Namibia, where the prevalences are much higher than perhaps they ever were in East Africa. And then, of course, one looks at West Africa and tries to understand those differences as well, and some have said, well, male circumcision may account for some of that, where it's a more common practice in West Africa. So, that's where some people are saying, well, maybe there's a genetic difference between Africans of the South versus Africans that are more in East or the West side, or maybe there's more Arabic influence or more Indian influence or more genetic mixing in the East than there was in the South. But there's been a lot of movement around that whole area. So that's sort of part A.